Hi, everyone. Welcome. I'd like to welcome you today to our second Bridge to Life series of webinars. This one on the elements of successful machine perfusion practice. I'm happy to introduce our two moderators for today. We have Luciano de Carlis, who's a professor of general surgery at the University of Milano Bicocca School of Medicine and director of the Department of Surgery and chief of the abdominal transplant program at Niguarda Hospital in Milan. He studied in Milan and trained in Pittsburgh in the US, as well as Essen, Germany, Tokyo, and Kyoto. He has performed as first surgeon more than 5,000 major operations in general surgery, with a special focus on HPP surgery, vascular surgery, and transplantation of liver, kidney, and pancreas. We also have Paolo Muiesan, who's professor of HPP surgery and transplantation at the University of Birmingham. He leads the living donor, auxiliary, domino, and DC liver transplant programs there. Other clinical research interests include normothermic regional perfusion, machine perfusion, and he is currently leading the surgical program for the treatment of cholangiocarcinoma. So thank you very much.
Thank you, Amelia. Thank you. Now I'm really moved to Florence, where I'm professor of surgery and doing HPB surgery. Now, I thought Amelia had a longer introduction, but I think we'll just get into this webinar, which is about machine perfusion and how could we start better than inviting Markus Selzner, who is one of the main players in machine perfusion in the world. He started his residency at the University of Cologne and became a resident in the Department of Visceral and Transplantation Surgery at the University of Zurich, where he completed a fellowship in liver and pancreas surgery and liver transplantation. And he was appointed assistant professor at that time and surgical attending. And then he went to Toronto, where he was a fellow, and then was appointed as senior staff at the University of Toronto, where he directs the UHN liver transplant program and is co-director of the abdominal organ transplant fellowship. Markus, thank you for being with us, and please start your presentation.
Yeah, thank you so much for the very kind introduction. I'm going to talk a bit about the latest developments in machine perfusion and how does it compare to non-perfusion techniques. I have no relevant disclosure to do. For my talk, I will first talk about the hypothermic oxygenated perfusion, also called HOPE. Then I will discuss a bit the normothermic perfusion. Then I will go over to normothermic regional perfusion. And in the end, I will talk about combined perfusion techniques, what has been done recently to get the benefits from all these three techniques. So as we know, in the liver field, there are different commercial machines available. LifePort has a hypothermic anoxic machine. There's the organ assist device who can do both normothermic and cold perfusion, oxygenated. Then there is the Metra device from Organox and Transmedic from a device which can do normothermic perfusion. So we have quite a number of choices and modalities in the liver field. First, I'm going to focus a bit on the hypothermic oxygenated perfusion work that has been pioneered by Philip Dutowski in Zurich, in Switzerland. This is a study from 2015 where they compared 25 patients receiving the HOPE perfusion with 50 patients who had static cold storage, all DCD grafts, and the group showed that there was a strong protective effect in the sense of decreasing of ALT post-transplantation. Also, the authors observed less ischemic cholangiopathy, which of course is a key feature for us in the DCD liver transplant world. There was overall less biliary complications, and there was an improvement of 1-year graft survival. On the right side, you see the ALT difference, and the early RF dysfunction on the second graft also was decreased. The same group followed up with a combined study between Zurich and Birmingham, where they compared 50 DCD HOPE perfused livers, which were all done in Zurich, with 50 DCD cold stored livers from Birmingham and another 50 heart beating donation livers also from Birmingham. The HOPE perfuse is done at 10 degrees, usually for more or less of 2 hours at the end of the static cold storage period. And interestingly, the authors again showed some benefits in function. Lactate at the end of transplantation was decreased in the whole perfusion group to a similar level like the brain death donor population, which is interesting because in the end, this is, of course, a key goal that we would like to have DCDs looking like brain death donors. In this study, there was no benefit in regarding of ALT release, so there was nothing in hepatocyte death function, and there was no difference in biliary bean levels 6 months after transplantation. But there was some interesting findings. There was a quite large decrease in non-anastomotic biliary stricture. It didn't reach significance, but the number of decrease or the difference is quite striking, and the study might have been just underpowered to show the difference. This certainly catches attention. There was no difference in the sense of complications of PNF, but there was an overall non-tumor-related graft loss. So tumor-related graft loss was excluded. And on the right side, you see the 5-year graft survival censored for tumor-related graft loss. Interestingly, there was no difference in the first 2 years, but on the long-term follow-up, actually, DCD whole perfused livers did as well as brain death grafts, clearly better than cold-stored DCD livers. This is another study from France this time. These were all heart-beating donation livers, but extended criteria grafts, so higher risk grafts. And the authors compared static cold storage versus whole perfusion in this study. They found a benefit in regarding of decreased ICU stay and hospital stay. There was also less early allograft dysfunction, which did not achieve significance, but the difference is quite impressive. There was no difference in graft loss or graft survival. The AST was different than the first day only, so it was a short-lived benefit in regarding of hepatocyte death, and there was some decrease of lactate clearance, indicating better early allograft function if whole perfusion was perfused. Then, very recently, a randomized controlled trial from the Netherlands. I think Robert Porte was the senior author in this. And they compared HOPE versus static cold storage in DCD grafts. The paper was clearly focused on the occurrence of biliary strictures, and the authors actually did find 6% in HOPE perfused DCD graft versus 80% of static cold storage graft, so a significant reduction of non-anastomotic biliary strictures if HOPE perfusion was applied. There was no difference in primary non-function, but there was a difference in early allograft dysfunction. The graph on the right side shows the same thing in two basically figures with different scales. Is the cumulative incidence of biliary strictures, further highlighting that the whole perfusion was protective in this sense, resulting in less ischemic type biliary strictures after transplantation. I'm now going to switch a bit gears to normothermic in situ perfusion. This was a randomized controlled trial by the Peter Fint group. Nasrallah was the first author. You're, I guess, all aware of this. 121 warm perfused livers versus 101 static cold storage livers. It was done with the Metra device from Organox. Interestingly, there was a significant extended preservation time in the perfused group versus the static cold storage group, and there was a bit more steatosis in the perfused group and in the static cold storage group. The authors had the reduction of AST as a primary endpoint, and there was a significant reduction of AST release post-transplantation. In particular, in DCD grafts, it was only a third of what you would find in static cold stored livers, but also in the overall population, it was decreased by 50%. But secondary endpoints may be clinically more relevant, that the discard rate of livers was decreased with perfusion technology. So we all can appreciate livers are harder to decline if they work well on pump. So this is probably reflected here, that surgeons became more courageous taking livers when they were on pump and functioning well. Also, there was a decrease of the post-perfusion syndrome. The recipients were more stable if the graft was perfused, and early allograft dysfunction was significantly reduced, likely a reflection of the decrease of the AST release. There was no difference in graft survival, very similar to the previous studies in the HOPE perfusion group. This study was not powered or designed to show graft survival. all livers in this study were acceptable for transplantation, so you would expect good outcome anyway in both groups. Then a key advantage or key potential advantage of warm perfusion is the graft assessment. This is here the VITAL trial from Mercantile, which looked at grafts that were declined in the entire UK for transplantation, and they were perfused and assessed. And the authors used a scoring system or criteria system. They demanded lactate clearance on pump during perfusion, also bile production. The pH had to be in the physical range, glucose had to be decreased, the flow and characteristics had to be reasonable. And with this assessment tool, they used 22 of the 31 grafts. So they had a conversion rate of 71% of livers that would otherwise have been not used for transplantation. And the one-year graft survival was comparable. So 86% versus 86% in both groups. Also, patient survival was more or less the same. There was no pulmonary function, but there was a higher degree of early aortic dysfunction in the perfused group, and they did see more biliary strictures. So the non-osmotic biliary stricture rate was 18%, and as we know, many of these people will need retransplantation probably down the road. But overall, for a population of decline graft, this is quite respectable and reasonable outcome. I'll now switch a bit gears. I will talk about now the normothermic regional perfusion, which has come up more recently. As you may be aware, is the circulation in the donor is restarted during the donation process and before the organs are retrieved. The blood circulation of the abdominal organs, at least in this case, is maintained. It's permitted in many countries, and a few centers even is mandatory. In France and Italy, perfusion, regional perfusion is done in all DCDs before retrieval. This is an interesting study, actually, where they compared controlled DCD grafts with normothermic regional perfusion versus super rapid recovery, a quite good number of patients. And interestingly, there was a quite large and significant reduction of biliary complications, in particular also ischemic type biliary strictures, which, as we know, is the Achilles heel of DC transplantation, and the impact was actually quite significant. Also, there was an overall decrease of graft loss, providing actually strong evidence that regional perfusion is doing something good for DCD grafts. This is a second study where they compared DCD regional perfusion with heart-beating donor transplantation, and the authors actually had a lower AST level slightly in DCD grafts post-transplantation with regional perfusion. Also, there was comparable bilirubin levels post-transplant and creatinine. So indeed, they could make DCD grafts look like heart-beating donor grafts by using normothermic regional perfusion prior to organ recovery. And this is the graft survival, which was not significantly improved, but certainly at least on par with heart-beating donation. And on the right side, there was no difference in post-operative complications such as biliary problems, early aortic dysfunction, or kidney dysfunction. So next, I talk about the multi-center trial. It was a combined study between Switzerland and 6 French centers. The whole perfusion was done in Switzerland and was compared with 6 French centers who did normothermic regional perfusion. And it was done in DCD grafts, controlled DC grafts only. The regional perfusion had a slightly improved graft survival, which did not reach significant. There was, however, significant reduction of early aortic dysfunction in normothermic regional perfusion compared to whole perfusion only. No difference in non-anastomotic biliary strictures, non-function, or artery thrombosis. But on the right side, I actually show you the graph of the post-transplant renal dysfunction. And that was actually quite impressive, that actually in the whole perfusion group, 30% of patients required dialysis, while this was only the case 5% in the normothermic regional perfusion group, indicating in my view that there was actually something significantly benefit in the regional perfusion group compared to the whole perfusion in this study. So now we're coming to combined perfusion techniques, which I would say is somehow the logic consequence. I think there is data that Hope perfusion and warm perfusion both do something good, and combining them is something of certainly very interesting. This is a Dutch study where they used DC hope perfusion first, then continuous controlled oxygenated rewarming, and then warm perfusion. And they did all it in the same machine. They used artificial oxygen carrier to avoid changing the perfusate. And they compared this with historic control groups of brain death static cold storage and DCD static cold storage. And very interestingly, the AST release in the combined DCD group was lower than in the heart-beating donor population, and certainly much lower than in the static cold stored group. Bilirubin and cholangiopathies were similar, I would say. Graft survival was excellent. I should mention that all combined perfusion patients in this livers received graft that were declined first in the entire Netherlands. So not only we were able to convert declined grafts into graft to use, also with excellent results comparable to heart-beating donation. This is an Italian study. As you were aware, that in Italy there's a 20 minutes no-touch rule, which makes DCD retrievals even more challenging. And therefore, as my understanding is, Italy normothermic regional perfusion is done routinely in all DCDs. And this study is compared patients receiving regional perfusion plus hope versus regional perfusion plus normothermic perfusion. There was 11 uncontrolled DCDs and 9 controlled DCDs. Most of the uncontrolled DCDs were in the warm perfusion group. And interestingly, 18 of the 34 grafts were transplanted. There was no non-function, quite reasonable level of early alveolar dysfunction, and only one ischemic type biliary lesion. So both technologies actually seems to be working really well, even under conditions with 20 minutes no-touch rule. The outcome was actually very encouraging. And this is a study where they have combined or compared regional perfusion with DHOPE versus regional perfusion with static cold storage. The risk factor or the risk population in the regional perfusion plus hope was different than in the static cold storage group. It was actually more risky patients were receiving hope than in the static cold storage group. And the key finding of this paper was there was a quite impressive reduction of acute kidney injuries if a DCD perfusion was done with hope and regional perfusion when compared to static cold storage alone. There was no difference in primary function or biliary complication. The ischemic cholangiopathy rate was very low, very reassuring that a good outcome was achieved with regional perfusion in both settings. The graft survival was certainly excellent, with regional perfusion plus hope slightly improved compared to static cold storage. And in addition, there was no vascular complications in the follow-up in this study. So I'd like to conclude my talk saying that both cold and warm perfusion seems to have protective effects for preservation injury, and they both seems to improve graft function. Also, both techniques seems to have some benefit for the reduction of ischemic type biliary strictures in DCDs. The normothermic regional perfusion seems to add significantly to this scenario, and the current data indicates that regional perfusion have a strong protective effect for ischemic type injuries, and certainly can enhance and further improve our DCD utilization. And I think the more recent studies indicated combining different strategies is particularly useful and probably the future way to optimize the donor pool and bring more organs to our patients. That's all my talk. I'd like to thank one of my research fellows, Yuki Noguchi, who helped me with the presentation, and I'm happy to take any questions later on.
Thank you, Markus. Luciano, can you please turn your microphone on? I'm awaiting questions from the public, and I invite you, as I wrote in the chat, to write questions. First, I have a question from Dongo Choi. Why does NRP improve renal function in the recipient, as we saw, Markus, in that paper?
So in animal studies, it has been well shown that liver injury can cause secondary organ failure, such as lung injury and kidney failure. So in mice models, especially in fatty livers, have been well documented that making the liver ischemic results in significant release of TNF-alpha and probably under other endotoxins, which can give you pulmonary edema and renal failure. So it's my belief that we're seeing secondary organ injury based from products released by the liver in patients probably who have compromised kidney function to start with.
Thank you. Marit Kalisvat is an expert in that. Luciano, have you got any questions?
No, okay. It was a very, very interesting presentation by, especially for me in Italy, because as all of us know, in Italy there is for DCD donors 20 minutes of time to declare the death of the donor. So we need, of course, it's mandatory for Italy for an Italian program for DCD and also for extended criteria donor to use perfusion machine in a machine perfusion program. So it's very interesting this presentation. But if there is no other question, there is other question. So we can move on with this question. One is why NRP improve renal function in the recipient? Okay. Another is hope versus standard cold storage, similar static, yes, similar cold ischemic time in each group. Is improvement a result of perfusion or just decreased cold ischemic time? This is the question.
Actually, can you repeat the question? I didn't caught
it. Okay. Hope versus static cold storage, similar cold ischemic time in each group. Is improvement as a result of a perfusion or just decreased cold ischemic time?
So it's a very good question. I mean, the whole perfusion is not replacing cold storage. It's done at the endoischemic perfusion. And I understand most groups will do this while they do the hepatectomy. They will perfuse the liver for 2 hours, and by the time hepatectomy is done, you can put the liver in. So you don't prolong cold storage. The key centers who have pioneered this so far was Switzerland and Netherlands and Italy, and certainly transport of organs is a bit less. If you go to US or Canada, our distance we have to cross in cold ischemia time will be much longer. So we don't know the efficacy. So the Swiss group proposes that the benefit of the cold perfusion is restoring ATP, which has been shown in some animal models. But there could be many other things that would be beneficial. In the warm perfusion world, it is even less clear. I think reducing cold storage, in my view, is the key. I think in the warm perfusion world, decreasing the cold storage time and assessing the graft is probably the benefit. Largely because we get better function parameters and we better know what to use and what to decline.
And Markus, Jeroen had a question and said, apart from thanking you, it says, what's your opinion on subnormothermic machine perfusion? Is there a place for that?
Well, actually, it's a great question, and we don't know that because it hasn't been studied really well. In animal models, subthermic perfusion at 30 degrees or 25 degrees decreases TNF-alpha release, and there's benefits. In rodents, there's clear benefit. We have not really looked into this in humans sufficiently. The whole perfusion is done as 10 degrees, so it's a bit warmer than static cold storage. And the machines, other machines doing 37 degrees. It hasn't been explored, but I think in theory, there could be a benefit in doing slightly subnormothermic perfusion, since Kupffer cells seems to be suppressed at slightly hypothermic temperature. So 30 degrees, 25 degrees results in Kupffer cell deactivation and less TNF-alpha release, which could be in theory beneficial. But the data is lacking, really.
There is another There is another question.
I say that because it's Yuri Boteon, and Yuri Boteon is a husband of Amanda. Both were fellows at Birmingham and big experts of machine perfusion. Sorry just because I want to introduce him, but he says for DBD organs specifically, there are different benefits expected for HNP and NMP. Which technique would be more promising?
Well, it's like at this point, it's like a religion that people strongly believe in cold perfusion, warm perfusion. I think we don't know. I don't know the answer. I think they have different strengths and weaknesses. I think the beautiful of the cold perfusion is it's very simple. It's quite safe. It costs very little. If the pump fails, it's not a problem. The liver is cold. So there are a lot of advantages in this regard. In the warm perfusion, you can delay the transplant. You can wait 4 hours, 8 hours on the machine and to study the organ perfusion, get parameters. You can plan your operation more electively, wait for biopsy results, call in a different recipient. It's a different strengths. You get different things.
That's exactly
and what I like is combining both. I think the future, in my view, should be we transport the organs cold oxygenated, likely, and then when you arrive in your home center, you put it on a warm pump, and then you see what you have.
It's just slightly expensive, but I think it'll get cheaper. Luciano is a famous doctor with the same name that has asked.
Yeah. Okay. I see there is another question. In your opinion, how far we are in keeping the liver alive on a machine?
So we have done it for 20 hours. I know that some groups have gone up to 24 hours. I don't think anyone has transplanted livers longer than that. I know that the Austrian group kept it for 3 days on the pump, but they didn't transplant the liver. They just assess function. So we don't know the answer, but I feel quite safe up to 20, 24 hours. I feel okay, but usually we don't need that long. Normally we can, within 15 hours, everything has been cleared, the biopsy is back, recipients have been checked. At some point, we have to exchange the fluid. I think the limitation will be that we have a closed circuit. It's like a petri dish with a cell culture. If you want to go longer, we have to do something about our fluid. But practically speaking, there's probably no indication at this point to perfuse longer. Once we do gene therapy or graft modifications, this may change. But for practical purposes today, 15 hours is probably reasonable and all we need to finalize all transplant arrangements.
Yes. Now, I lost one question, but Robert Fisher was asking you what device do you use right now, and quickly what kind of perfusion is optimal for fatty livers?
So fatty livers is difficult because I think the perfusion is ideal in my view for DCDs. Fatty livers is good if you can keep the cold ischemia very short. If you use your device as a back to base device and you have the organ cold stored first and you go and pump in your home center, the fatty liver might have already significant injury and it may not be as good. You still get the assessment of it. But ideally you take DCDs, which are the parenchyma is healthy, and only the ischemia was the only injury. I think the different devices are doing probably very similar things. So I'm not attached to any of the companies, and I think all of them provide similar perfusion and technology. Whatever you're most comfortable with is probably good. In Toronto, we use the Metra device for Organox.
Markus, one last thing. You seem to go by the in some of the papers you quoted by the AST and of course EAD. It's the same thing because it's based mainly on transaminases.
Yes, on the AST, yes,
but do you think they're really that important in judging a device in machine perfusion?
So I think AST is a marker of cell death, and of course we can lose a lot of liver cells and nothing changes in outcome. I think it's a surrogate marker of how much ischemic injury you have. So if AST is not reduced, I think cell death wasn't prevented. It's a different question, it's a clinical relevance, but I would say any machine that claims to prevent preservation injury should also have some ALT-AST difference because more cells remained alive and less cells died. Of course, the real endpoint we want to have in DCDs is ischemic tired biliary injury, and can we convert non-declined graft into transplanted graft? This is a real endpoint. But I would say I would still look at the AST-ALT as an interesting parameter, but the real outcome would be function post-transplantation, and can we do things which we are not daring to do with cold storage?
Thank you. Luciano, I think maybe we can take this last question of Emmanuel, if you want to read it, and then...
Yeah, there is is in our experience the use of HOPE versus SCAs tend to increase rather than decrease the total cold ischemic time, because we have to delay the recipient surgery to allow minimal perfusion time. Don't you think this may be a disadvantage for HOPE?
So I would say, in theory, you should, with the HOPE perfusion, improve your ATP levels, and the mitochondria should be better. So hopefully, if it's true, what is the underlying hypothesis is that the liver gets better with the HOPE perfusion. My understanding is that many groups do not extend cold ischemia time, but start the HOPE perfusion when the liver arrives, and while the patient gets intubated, worked up, you do a hepatectomy, you do the HOPE perfusion in this time. So my understanding is that you shouldn't extend the cold ischemia time. You just use the 2 hours you have anyway between organ arrival and cross clamping for the HOPE perfusion. So I wouldn't actually make a corner. I would just convert it.
It's the hepatectomy time, isn't it?
Yeah, exactly. In Toronto, it takes an hour at least to take the patient to sleep, intubated, and lined up. And then you still have an hour and a half for hepatectomy. So this is easily 2 hours without any problem.
It is an easy one. Let's do this last question. But do you like better cellular or cellular perfusates?
Well, this depending what you do. If you have warm perfusion, you have to have a cellular perfusate. If you have a cold perfusion, you cannot have blood cells at 4 degrees. Blood cells at 4 degrees would destroy it, and you would lose a graft. So, interestingly, the Dutch group has used an artificial oxygen carrier, which can do both, which is actually quite nice. We may need more information about the safety and other factors, but that might be a future way to go. So at this point, if you are warm, you need blood cells. If you're cold, you don't.
Thank you, Markus. It was an excellent overview, and you got a lot of questions that you answered beautifully. Luciano?
We can go to the next presentation. Okay. So it's a pleasure for me to introduce Georg Lurje. He's a consultant, HPB and transplant surgeon at the Charité Berlin. His research interests include the reconditioning of borderline transplantable donor organs, ex vivo machine perfusion prior to organ transplantation, risk stratification for potential patient with primary liver tumor, and mechanism of ischemic reperfusion injury. Dr. Lurje is a review editor of Frontiers in Physiology, as well as a principal investigator in the HOPE ECD DBD clinical trials Gov number, okay, and the HOPE NMP clinical trial machine perfusion multicenter endometrial control trials. So there is very important trials concerning perfusion machine, the perfusion program. In 2020, he was a recipient of the von Langenbeck Award at the German Surgical Society and the ILTS Rising Star Awards. So please, with the presentation, Dr. Georg Lurje.
Yes, thank you very much for your kind invitation. So to speak here in this webinar, I will try to share my screen, and please let me know if you can see everything. I'll go into presentation mode. Yes. So do you see my slides?
Yeah.
Perfect. Yes, again, thank you very much for the invitation to speak here and for your kind invitation introduction. So the topic is how to start a mesh and perfusion program. It's a little bit difficult of a talk in my understanding, and I'm lucky enough to share a little bit of my experience in Germany. Germany is a quite special situation for mesh and perfusion, in my opinion. And as I was involved in establishing a mesh and perfusion program in a big German center in Aachen, Germany, and now in Berlin. So we all know this, of course, under ideal circumstances, we have a 90% 1-year survival with liver transplantation. However, in Germany, our 1-year and also 5-year survival rates are significantly lower. And this has multiple reasons, and some of them I will tell you about later. One important issue is also that the implementation of mesh and perfusion in Germany was significantly delayed in comparison to many other European and non-European countries. So in Europe, we do not have the European Union. For all the people who are not from Europe, this might be interesting to know. So we have Eurotransplant, we have the British Transplant Society, we have Scandia Transplant, we have Swiss Transplant, among others. And also we have other transplant organizations. It's all very decentralized. And Germany, among them, Germany is the world record low organ donation rate holder with more than 4 times less organ donation rates than in Belgium or in the Netherlands. Also, I think this might be very interesting for many people to know that Germany has no DCD liver transplantation program, and this is in sharp contrast to many other European countries. Actually, we do not have a DCD program still. Likewise, Armenia, Belarus, Cyprus, Estonia, Georgia, France, and Finland. So we are the only country with these other countries who do not have a DCD program in Germany. So we have significant organ shortage, which forces us to implant organs which in other countries would not be transplanted. For example, this organ was transplanted here in Berlin. It's a fibrosis grade 2 organ, which was arriving from a donor with alcohol abuse and 30 minutes reanimation with LFTs around 2000. This organ arrived in our center, was not deemed suitable for one recipient. It was allocated to another recipient after it was brought back to Eurotransplant, and ultimately it was perfused on a machine, and it was successfully transplanted later on with this device, actually from Bridge to Life, which is the VitaSmart device. Here, by the way, we had almost 19 hours not cold ischemia time, but total preservation time. Total cold preservation time of 19 hours, almost 5 hours dynamic preservation, and 13 hours of cold ischemia upon arrival in our center. Mesh and perfusion is a well-known concept which was described a long time ago by pioneers Alexis Carrel and Thomas Starzl, of course. And devices today look very different. And I would say that mesh and perfusion is standard of care in most European countries: Spain, Italy, UK, Switzerland, Netherlands. It's not all countries, but I just wanted to stress out that in most European countries, mesh and perfusion is well established. In Germany, we have 23 liver transplantation centers for 80 million people, and we also have a very decentralized map of Germany in terms of mesh and perfusion. So now we have 8 out of 23 centers with newly established ex vivo mesh and perfusion programs, which are in real clinical use. So there are 8 centers who are actually perfusing or in the process of perfusing, and most of them started perfusing within the last 1 or 2 years. In Aachen, that's this city here in West Germany, close to the Dutch border, where I used to work for 5 years. We established a mesh and perfusion program back in 2016, and at that time we were one of the, or within a short period of time, we were the biggest mesh and perfusion center in Germany. So now I moved to Berlin, and since then we perfused between 50 to 100 organs with an annual caseload of 20 to 30. So those are all the mesh and perfusions who are actually available on the market with CE mark devices. And as Dr. Selzner already mentioned, so I don't want to stress out on that too much, but of course we have different modalities. We have normothermic, midthermic, and hypothermic technologies. And I want to stress this topic a little bit, the difference between upfront and anti-ischemic, because I think in general people try to, or generally mix it up a little bit. So of course, the reduction of cold ischemia is the main advantage of normothermic mesh and perfusion. The landmark trial of Peter Friend and David Nasrallah was a upfront mesh and perfusion trial. This requires the mesh to be brought to the retrieval center and connection of the organ and bringing it back to the center. The other concept, and that's what most centers and most countries in Europe do, it's anti-ischemic back-to-base perfusion, either with hypothermic or with normothermic, even though for back-to-base normothermic perfusion right now, there's no data at all to support this. Even though, nevertheless, the concept of anti-ischemic organ preservation is the prevention of ischemia reperfusion injury plus the testing of viability. So I will skip that a little bit, even though, especially since Dr. Selzner already talked about it, but of course, this Nature Landmark feasibility trial, that was the first man trial, also showed high safety of mesh and perfusion. That was upfront, and all organs which were put on this trial were pretty much healthy, I would say. This is the landmark paper from the Groningen group, Porter, and was published, everyone knows, in the New England Journal of Medicine. And I will skip that, showed superior result in the DCD setting. And it doesn't only show superior result in the DCD setting, but also these data are the first data in humans for back-to-base mesh and perfusion. So in summary, we have the NMP trial, the Peter Friend trial, and we have other non-randomized control trials, evidence for normothermic perfusion, and for HOPE, we have less biliary strictures after 6 months after DCD liver transplantation, as recently published in the New England paper. And we have 2 other trials, one trial which was initiated in Aachen in 2016, and the other trial, of course, from Philip Tutkowski, where we are waiting clinical data. So clearly 2021, in my opinion, and 20 are, it's true prime time for mesh and perfusion worldwide. Organ recovery units are developing everywhere. So this is in Groningen, that's the organ recovery unit in Rotterdam, and that's the organ recovery unit at the University Hospital in Aachen, where I used to work until last year. So what do we want to achieve with mesh and perfusion? I think this is really important to think about before we actually try to establish a mesh and perfusion program. We want to repair or recondition damaged organs. We want to test viability. And viability testing is not only possible in normothermic perfusion, but there's also very good data coming out and has already been published by the Zurich group from Andreas Schlegel and Philip Tutkowski, that FMN testing is a very good method to test viability in cold. We can improve operating room logistics, timing. This can also be done, by the way, not only with normothermic, but also with hypothermic perfusion. We have organs which were perfused cold more than 6 hours and longer. We have we want increased security with mesh and perfusion, of course. We also need good usability. So ideally not many errors and failures with the machine. And of course, we also need to pay for it somehow. Someone has to pay the bill. And ultimately, we want to improve outcomes. So those are the most important things we actually want to achieve with mesh and perfusion. For this, we have different technologies: cold, warm, upfront, back to base. So we know with mesh and perfusion, we can repair, we can predict function, and we can prolong preservation. Those are the 3 things we already know. And data which is out there already tells us that we have reduced ICU stay, less cost, less complications with hypothermic and also probably with normothermic perfusion if in the upfront setting. And we aim to achieve better graft and patient outcome. This has not been proven in an RCT yet. So what are the important considerations when we aim to start a program? Let's say one important thing is the retrieval teams. So in Germany, we have a very decentralized retrieval setting. in comparison to the United Kingdom, where there are very centralized retrieval teams. The other issue is mesh device capabilities. Can we transport the organ? So, for example, yes, we can transport the metro system, but no one is doing it anymore because the battery is frail and it's complicated, and a whole team has to go out. So logistics and usability for upfront perfusion are complicated. So people tend now to perfuse back to base with the Organox Metro, for example. So other things to consider are, so who's actually connecting the organ to the machine? Is it a medical student, a PhD student, a transplant surgeon? How do we transport those devices? Most devices are not transportable, actually, in Germany, those ones we use at the moment. Who operates the device? Is it the perfusionist, transplant surgeon? In my opinion, until now, it's always the transplant surgeon is connecting the device, especially in the normothermic setting. And who's paying for it? So in Germany, health insurances are not paying. Until now, I have applied for multiple research grants, and we also got research funding. It's very painful, and we try to convince our hospitals ultimately to pay for it as well. And so again, that's the situation in Germany. And with regards to retrieval, that makes mesh and perfusion upfront extremely complicated. We have so many centers. We have 23 centers for 80 million people. In comparison, the UK, we have 6 centers for 60 million. And the Deutsche Stiftung Organtransplantation, the DSO, that's the organization who's actually organizing logistics and retrieval. We have 840 retrieval surgeons in Germany. That's quite a high number. So we have a lot of retrieval surgeons. So it's basically impossible. If we are, let's say, in Berlin, we receive a liver from Heidelberg. How is our machine getting to Heidelberg? Who's connecting the organ in Heidelberg and bringing it back to Berlin? So those considerations about upfront or back to base are important when you think about establishing a mesh and perfusion program. What are the devices? The devices out there on the market are the ex vivo perfusion for lungs. They have now joined together with Organ Assist, and they have their other devices, organ recovery system, Transmedics, and so on, Organox, and of course, Bridge to Life with a new device. In Germany, we are now until now, the only center who are also actually routinely using this device. And the second important question is, I have already mentioned it a little bit, who is actually using the device and who's connecting. And I think in the hypothermic setting, once a medical student or a PhD student are trained to do it in a small group setting, after a while, I think it's safe to let someone be trained who's not a transplant surgeon to connect the liver, at least in most parts, to the organ. If there's a system failure, Dr. Selzner mentioned it, we have static cold storage. On NMP, I think it's a much bigger problem, no matter if it's upfront or back to base. If there is a problem with the device, a kinking of a vessel can be very little problem, and if we do not react appropriately quick enough, the device is gone. So what about elective time, daytime surgery and liver transplantation? Well, I mean, someone has to connect the organ to the graft, the organ to the machine. So in my opinion, there are 2 teams necessary. One team who's connecting the organ and the other team who's probably implanting. So it's, again, more logistics, more people. And those are all things to consider when you establish your program. Then another thing, which is, I think, quite significant. So what are the actual costs? So the Organox Metro device is 150,000 euros in Germany. And the kits, including red blood cell and other medications you need to run a liver on this device, are around about 10,000 euros in Germany. For the hypothermic technology, it's significantly less expensive. So the VitaSmart costs 36,000, the Liver Assist 95,000. The kits are, including solution, close 4,000 and 5,000 euros. Those are all list prices. So overall, it's an expensive tool, less expensive than robotic surgery, but it's expensive. And this needs to be justified in front of the hospital officials. What about medical insurances? So in the Netherlands, for example, kidney mesh and perfusion is standard of care, in my understanding, but maybe Dr. de Jonge can tell us more about it. Kidney perfusion is paid by healthcare insurances, and there are also attempts to get it paid in the DCD setting now. The New England paper is out. Hospital funds, lots of convincing and negotiating with people in the hospital who want to keep the cost low. So how do you convince those people to fund a mesh and perfusion program? And of course, research funding, as I said previously, lots of grant writing and cross-financing to quite expensive technology. Daytime elective surgery in Germany, that's also a consideration. I think most hospitals don't have a particular interest in that because what's happening when we do our liver transplantations during the day, our elective lists get canceled, and generally we tend to transplant more at night because actually people want that to be like this. So we can also operate our electives. So a good way to convince hospital managers is cost optimization and clinical benefits. I think it's a good way to establish a mesh and perfusion program with mesh and perfusion research and clinical evidence. And that's what we did first in Aachen and now in Berlin. We added all ECD organs which were transplanted were put on clinical trials. One clinical trial is the HOPE ECD DBD trial, which is completed and now submitted and under revisions, and it will be published soon. And the other trial we initiated in Berlin is the HOPE NMP trial. I will show you quickly a little bit of that because I think it's also important to do this as part of a mesh and perfusion program to follow it with clinical science. So that was the HOPE ECD trial, which we initiated. And there was a multi-center trial of the University of Aachen, the Charles University in Prague, Charité in Berlin, and the University Hospital in Munich. And organs were randomized to cold versus HOPE, and it was a stratified randomization, which was stratified by expected cold ischemia time and macrosteatosis. Those were organs we transplanted. Left, it's a heavily steatotic organ, which was transplanted in Aachen, Germany. That was transplanted in Munich. And the trial completed after 3 years, and median donor age was 72. At least 2 ECD criteria, and the ETDRI was 2.1, so in comparison to 1.6 of the Peter Friend Nature study. So those are until now unpublished, but I think interesting data. So we could also show that peak ALT is significantly reduced in comparison to cold storage, and peak ALD as a surrogate for organ injury was lower on all 7 days within the first 7 days post-operatively. We could also show a significant reduction with HOPE for 90-day comprehensive complication index, but also for major complications, Clavien-Lindau 3A, length of hospital and ICU stay. And even though, of course, this trial was not powered, but considering that 1 year survival in Germany is between 70 to 80%, we had a very good 1 year survival of 91% graft and patient survival in a highly significant or in highly injured ECD allografts with an ETDRI of 2.1. So we had a significant reduction of major complications for HOPE. We had a significant reduction of 90-day CCI, ICU hospital stay, but I think that's very interesting. Costs were in fact less for HOPE treated patients than for cold storage patients because they significantly had also less complications. When you establish a mesh and perfusion program, I think it's not only important to do it in parts of it, in a setting of a trial, but also research and translational studies. So those are human samples who went from our trial. This is a tunnel apoptosis staining where you can see apoptosis under HOPE, no staining, and under cold storage, much apoptosis. It's just one image. We are doing the translational studies right now. So in summary, this trial showed good outcomes for HOPE, and we were discussing about this quite a lot, so I'll keep it short. But of course, hypothermic back-to-base versus normothermic back-to-base, those are important topics to discuss. What are the ideal modalities and which modalities should we actually use? And so this is something we wanted to investigate, and we initiated this HOPE NMP trial here in Berlin, which already started. We included the first 2 patients. And for anyone who's interested, you're welcome to visit our webpage, hopeliver.com, to get more information on that. So it's a stratified randomization again, and it's a 1-to-2 randomization cold storage. We kept it in as a control group, back to base normothermic perfusion versus back to base cold perfusion. 213 patients total, 43 patients in cold storage and 85 in each arm. So it's a 3-arm randomization study. It was initiated in January, and here in Berlin and Hanover and Heidelberg, 2 other major German centers, they have submitted and their IRBs, and they have already been approved. So I hope that they will also start to recruit patients within the next 1 or 2 months. Aachen is also in the progress of doing so. So I will skip that a little bit because we are running out of time, but I think 2021 is very important for establishing mesh and perfusion programs. Why? Because clinical data is coming out to support this. We have the New England paper from Groningen, we have our trial, we have Philip Dudkowski's trial, which is coming out, and we have less costs actually with mesh and perfusion. And more evidence will help to implement routine use of mesh and perfusion worldwide. Back to base, I think it's easier, more realistic in real life scenario, at least in Germany. New trials are needed, not only comparing cold and warm anti-ischemic, but maybe also the combination of both and controlled oxygenated rewarming, what Dr. Selzner mentioned before. And new data will also help to convince medical insurances, but also hospital managers to implement and fund those programs. And in my opinion, infrastructure comes with experience and usage. So in the beginning, it's very good to have small teams to install the machine, but also to keep the machine running. Thank you very much for your attention.
Thank you. Thank you so much. Luciano, turn on your mic, please. I'll start with a question that Paolo Martins posted that somehow disappeared at some stage and now reappeared. And that may have been well also for Markus if he's still on, but it's with normothermic perfusion after co-preservation. You have 2 hits of ischemia reperfusion injury. Could this be the reason why the randomized study did not show improvement on ischemic cholangiopathy? What do you guys think? Quickly, because we have a lot of questions, which is good.
So I didn't really understand the question because
2 hits of reperfusion injury with normothermic perfusion.
Yes, of course, yeah.
So is this the reason why this is the only method that doesn't really show any advantage in ischemic cholangiopathy? Because you have it with
well, for normothermic, I think that's very important to. I think it's very important to mention. There is no data for back-to-base perfusion at the moment, so we don't know. I mean, the only trial, randomized control trial, which is out, is the Oxford Nature study. That's upfront perfusion with very good organs, so it's a completely different setting. So for anti-ischemic normothermic perfusion, exactly what you said, cold, warm, it's no data out there, in my understanding, not from randomized control trials.
Well, there was the Birmingham trial as well, but that again showed no advantage on ischemic cholangiopathy. Markus?
Yeah, I think as Georg said, the Orglox trial, the randomized trial, wasn't designed for that. The population was too good to show difference. And then the Vital study had quite significant, or even the Birmingham study had significant ischemia before they went on pump. So I don't think you reverse this, you stop the ischemic injury, but if you have already a DCD with 12 hours cold storage before you go on pump, then you're going to reverse this. I think the trials haven't been designed and done yet. I do believe there will be a difference. We're waiting for the US study to come out. I wouldn't be surprised if we will actually find benefits if the population is well defined. Regional perfusion, I think, is really overwhelming evidence for reducing ITBS at this point. That's probably the best bet if you want to target DCD cholangiopathy.
And hope as well, because we've seen with the New England Journal of Medicine paper from Robert Porter, that's explicitly for that purpose. So that's pretty clear as well. Luciano?
Yeah, we have no data. We have no data about this to have to have a good opinion in one or the other situation. I personally prefer hope because there is not this tweet of temperature, but is not in other situation. I have used normothermic machine perfusion without any problem. But I do use hope in all DCD because it's more for logistic reason and to avoid this two kind of it. And I think also if there is no data, I prefer this. I don't know if I am right, but this is my opinion.
We have questions from a first question from Jeroen, national policy.
Yeah.
That's correct, but only for kidney. As this has to be proven with a randomized control trial, beneficial. Process costed 5 years. More than a question is a remark. Luciano, can you continue?
Yeah, there is another question. Yeah, there is another question. In Brazil, they have the similar situation that in German, and they ask in regard to DCD, the absence of DCD and the relative low organ donation rate, and he asked what will you be your advice for someone considering start a program if you have normothermic machine perfusion, hypothermic machine perfusion. How do you select organ for each technique, and what is which modality of machine perfusion have you used to start in Germany? This is the question.
So I think not only in Germany, most centers started with hypothermic perfusion, and I think it's a very good idea to do that. As we have pointed out multiple times now, it's not prolonging the transplantation, the procedure, or logistics around it. So HOPE is very cost-effective, very safe, and very effective, as proven now by 2 or 3 RCTs coming out this year. In different settings, ECD, DBD, or DCD, so in all different settings. So I would definitely start with HOPE, as it is safer and easier to do. Normothermic perfusion, I think it's also very interesting. We are doing both here in Berlin, so at least that's what we did for normothermic. We started with healthy organs in the beginning to get used with the process, the medications and drugs which needs to be added, and to set up everything. It's more complicated, takes more time to prepare everything. So yeah, I would start with HOPE, and I would add normothermic with healthy organs for the beginning.
Another question is, which DBD organ do you put on the machine perfusion?
Well, I mean, that's the holy grail. What is a DBD organ, and what is an ECD organ? So we put all ECD organs from DBD on the machine. But what is the ECD? What is an extended criteria donation organ? I mean, there are whole papers about this topic, but generally we use the German Transplant Society guidelines, over 65, elevated transaminases, steatosis as proven on biopsy more than 30%, and intensive care days, and so on. So ECD organs we put now routinely in our center on the pump.
Yeah, and another, what criteria do you currently use for hypothermic machine perfusion of DBD livers?
Flavine mononucleotide. So we are in the process of doing that. So we haven't started yet to do viability testing in the cold, but with help of Philip Titkovsky and Andrea Schlegel, who also helped us and me here to establish things, we will also do FMN testing soon. I hope that companies will implement this in their devices, and in the meantime, we will do it on our own. But for viability testing in the cold, we do FMN testing as a surrogate marker for mitochondrial metabolism in the cold.
Then there is a question for both speakers. What are your thoughts on the advantages of NRP over dope or vice versa for DCDs?
I think that's probably a good question for Dr. Selzner, because I have no experience with NRP and DCDs in Germany.
So I would say NRP makes a lot of sense. I think restarting warm recirculation is making sense, because we all know that livers take warm ischemia quite well if you don't make them cold. So there's a lot of theoretical background for that. The studies so far have uniformly shown significant reduction of ischemic type biliary injuries, which is really appealing for DCD. So I think the data is not really finalized. We certainly need more trials, but the initial data is really promising. So I think, in my view, for DCDs, regional perfusion is something to pursue, likely in combination then with either HOPE or warm perfusion. This is my view of perfusion, and with regional perfusion, we are prepared to accept much longer withdrawal times than with static cold storage. So we will extend the criteria and likely get many more DCDs than we are using currently.
Okay, there is another question and about the biopsy. Do you do pre-implantation biopsy in every case? How long do you wait for the results?
So actually, we do biopsy on every patient where we request a biopsy to be taken, which is mostly ECD organs. So in Germany, it's no problem. I know in other countries it is, but in Germany, we get frozen section in the middle of the night. So all patients going into this trial have a frozen section upon arrival of the organ in the center.
Markus,
so actually, the problem is we also get frozen sections, but what I really want sometimes is a trichrome staining. I have this donor with Hep C or other issues, or very old. So what the warm perfusion does, I can delay my transplant 8 hours, so I can get a proper biopsy stained for whatever I like. So I don't have to rely on the frozen section. I get a formal pathology assessment from a liver pathologist 6 hours, 8 hours later. So this is actually, I find, advantage for the warm perfusion. I can plan the operation. I can wait for the biopsy results. I'm not rushed, and I can talk to my colleagues, look at the biopsy myself. So this enhances. The frozen section is good or bad for fatty livers, but the moment you like to look for fibrosis or these things, it's underscoring.
Jeroen, do you do that as well?
No, we do not do routinely frozen sections. And actually, we have the same problem like Markus, that it's hard to get a liver interested pathologist at night. Usually they is like, ooh, am I on call? Is there any pathologist on call? So that's difficult. So I think that might be a role for normothermic machine perfusion to delay safely until daylight in these cases that you have to make a difficult decision.
There is also a question from Dongo Choi. What do you think about cholangiocyte cell therapy or biliary organoid transplantation for preventing biliary injury after machine perfusion? That's a tough one.
Maybe you want to start. You have more experience, Dr. Selzner.
Let's research, I would say. We're not there yet. Future, I would say a lot of things we can do with organs on pump. We could give anti-inflammatory cells. We could try to increase IL-10. We can do gene transfer, but that's all research and not for today. I think in 10 years from now, we will have that. In 10 years from now, we will perfuse livers for 3 days and we do all kinds of modifications. But today, it's about decreasing preservation injury, assessing organs, and reducing the biliary injuries. We're not at the point where we would transfer genes or giving cells in clinical practice, but it's coming. This will be the case down the road, but it's not here yet.
20 years ago, they told me that we would have had gene therapy in 10 years, and that we would have transplanted livers from pigs again. That never happened. Hope that now the research accelerates
Or maybe I may suggest the paper recently by some Patriotis group in Cambridge, because they reseeded part of a liver on a pump with cholangiocytes, and actually 60% of the bile duct was replaced by the infused cells. It was impressive. So not at all clinical, but I think the 10 years is maybe now realistic.
All right. Excellent. Then we can move on to the last but not least speaker. Jeroen de Jonge is quite an amazing surgeon in Rotterdam, in Erasmus Rotterdam. He did his training in the Netherlands, of course, at Erasmus, but also he did a fellowship with Kim Oltoff's group at UPenn in Philadelphia. He's a senior staff in Erasmus Transplant Institute. He has published very widely in many fields, scaffolding of organs, machine perfusion, and amelioration of grafts. So he's also started the Netherlands NRP program, and he's been one of the senior co-authors in the recent DOPE study, which has just been published in New England. And Jeroen is a board council member of the Dutch Transplantation Association. Jeroen.
Thanks so much for your kind introduction. Hi, everybody. I would like to start by thanking the organization committee and the organizers for inviting me, and obviously Bridge to Life for supporting such a great webinar. I have to disclose that I do have a research project in which Organ Assist is involved as a partner for less than 15%, so probably that's forgiven, no other things. And after a lot of talks of really high quality, probably it's dazzling you as well, because we had old school, simple static cold storage, and now you can do end-ischemic HOPE, you can add oxygen to normal thermic machine perfusion, you can do this gradually, you can put a liver graft on normal thermic machine perfusion during transportation, and under the line is all the NRP stuff that has come along. I won't talk about that today. I was a little lost in the woods. And then we have cold woods and warm woods. So I would try to talk about HMP, which is like hypothermic machine perfusion without oxygen. I think it's important to make the difference between HMP and HOPE or DHOPE, which I consider pretty much the same. And I will talk somewhat about NMP, the rewarming NMP, subnormal thermic NRP, and so I won't talk about NRP today. So if things start to be difficult, I tend to go back to the physiology. And the fundamental issue that we have if we want to transplant an organ, any organ actually, is that we have to disconnect it from the blood supply. Although I know there is a ischemia-free transplant done in China, but usually you have to disconnect from the blood supply. And then there is no oxygen to the tissue, and actually that's an emergency. So the tissue has to shift aerobic to anaerobic metabolism, but this is very quickly self-limiting with the production of lactate and all kinds of protons. And the pivotal step here is that there is ATP depletion, and ATP is the currency of your body. Everything that's happening inside a cell has to be paid by ATP. And it causes cell depolarization because the pumps don't act anymore. And intracellularly, the protons and also calcium concentration goes up, and this will kill your cell. So if you look at this graph, and I think it's always very interesting to look how quickly ATP is dissolving, and this actually like the money in your pocket, it's gone before you know it. 50% reduction within 1 minute time. So when the oxygen supply stops, the clock is really ticking. And 60% of this energy actually is being used for housekeeping things that you can't just do not. And all the magic is happening here in the mitochondrion, where in normal conditions, the glucose from your fruit is being converted into pyruvate, and this pyruvate can go to the tricyclic acid cycle here inside the mitochondrion, and it will yield you 34 ATP, which is much more than the 2 ATP that you can yield when glucose is diverted to pyruvate and lactic acid. So that's a large difference in efficiency. So what's happening inside the mitochondrion during anoxia? And this is a very elegant paper, and I would encourage you to read it if you have interest in machine perfusion. It's been published in Nature in 2013 from the Cambridge group of Michael Murphy. And he showed for different tissues, but we concentrate on liver, that there is an accumulation of succinate. And this is happening in the mitochondrial membrane, which you might know from the pictures of Philip Dukowski. And from left to right, you can see complex 1, then this SHDH, which is succinate dehydrogenesis. And that's where the succinate is actually piling up. And at reperfusion, it's the panel on the right side, this succinate is actually forced back through the same enzyme to form fumarate. And in this process, a lot of energy comes back and is used to transfer an electron back from complex 1 to complex 1. So this is what's called retrograde electron transfer, and it's not good for you, because normally the electrons from complex 2 should go to 3, 4, and 5 to generate ATP. And what you see in the panel on the right lower side is that actually the electrons can react to the superoxide radical. And this is what we call ROS, a reactive oxygen species. And within 10 minutes after reperfusion, you get a lot of these ROS formation because the succinate goes the wrong way and electrons are formed there. So now this is actually what's happening during anoxia and subsequent reperfusion. That's why we call it ischemia reperfusion injury. And that's why people thought for a long time that dealing with oxygen during machine perfusion was quite dangerous, because you might trigger from free radicals, which you can see here, through the mitochondria into cell death and release of DAMPs, danger-associated molecular patterns from your mitochondria, which can evoke an immune response and make things worse. So the only thing that we thought was beneficial is lowering the temperature, because then we would actually save this ATP, and it's simple thermodynamics with the Arrhenius equation. In any system, like the energy in the system depends on a coefficient in which a temperature is there, and it's nonlinear. So for every 10 degrees that your body temperature goes down, the metabolism is reduced by 50%. So if you imagine going from 37, 27, 17 to 7 degrees centigrade, you end up with about 12% of metabolism left. And as we saw in the previous slides, there are drawbacks like cell swelling, because the proton pumps, they don't function anymore. You get acidosis from lactate accumulation, and upon reperfusion, we get production of these ROS, these radical oxygen species. Now, I think this is a key publication because, as you know, we started transplant with Foco-Belzer by doing hypothermic machine perfusion. But then, having the UW preservation solution for like decades, we could do simple or static cold storage. And now James, he showed that in a series of 20 ECD DBD livers, by perfusing the liver back to base, so in his own center for a few hours, he could actually lower the allograft, early allograft dysfunction from 25% from a historical cohort to 5%. So the main criticism was like, this is dilution in the system of transaminases, maybe a little of the same criticism that has now been attributed to the Peter Friend study that I will come to later. But something else is happening, and that was shown like 7 years later by the group of Robert Porta, and that is that if you run fluid along your endothelial lining, this is preventing activation. So what you can see in the black bars is that simple cold storage will activate your endothelium and with release of thrombomodulin, and this is much less if there is some fluid and shear stress along the organ. So endothelium doesn't like still standing fluids. And probably this will trigger immune cell activation, diapedesis, and inflammation. Another hallmark paper is this paper from the Zurich group, and this is a rat study on the left panel and a pig study on the right panel. But what they dared for the first time is to add oxygen in the situation of machine perfusion. And what you can see, and these are the open lines, they did then a 3-hour HOPE session. So now it's gone back to 2 hours because you can see that the peak is at 2 hours. So this is the energy state of a mitochondria. So what you see is that during the HOPE, actually energy is piling up in the mitochondrial system, and then the red liver was taken from ice and transplanted, so the energy disappears. But upon reperfusion, you see a clear difference between red livers that had the previous uploading of energy, of oxygen, and the red livers that only had static cold storage. And on the right panel, in pig livers, they showed that during this process, actually the ATP content of the tissue was increasing. So if you remember the cartoon of the mitochondrium, actually what's happening during cold storage with oxygen is that these electrons, they go through the higher complexes and they generate ATP. This is Philip's cartoon from gastroenterology. Ischemia, complex 1 and 2 are the bad guys with the succinate accumulation. If you go to the left lower panel on normothermic perfusion, what's happening? The succinate flows back to fumarate. There's energy generated, and this energy and the electron goes to a complex 1 and creates the ROS, while on the hypothermic machine perfusion, actually this is not happening, and the electrons, they flow to complex 3 to 5, generating ATP. So I think this is really the basis of what's happening during oxygenated cold perfusion. The requirements for energy are quite low, 10%. Oxygen is available, and actually the succinate is worked away before a warm reperfusion occurs. This study, I think Markus already showed a cohort from Birmingham, from Paolo, compared to the Zurich cohort from Philippe. And actually, I think one of the amazing things was that there is a large difference in ITBL, ischemic cholangiopathy, also a little in primary non-function, which might not surprise you, because actually that's what we think, like all the hepatocytes with the mitochondria get better. But also the biliary system is getting better. And that was surprising to me until I found this publication from Keith Nowak from 1993. And actually he showed that the cholangiocytes are much more resistant to anoxia than the hepatocytes. And it was amazing to me. They can stand proteolysis 2 times better. And even after 1 hour of anoxia, the amount of ATP in cholangiocytes and hepatocytes is not different. But what they can't stand is reperfusion. They are susceptible to reperfusion. The ROS formation in cholangiocytes is 5 times higher. They don't have the reserve of glutathione to buffer this ROS formation. And if in the panel on the right lower side, you can see culture conditions for 6 hours under aerobic conditions. So this is like standard. Anaerobic, they don't like that, but still they're hanging on. But what they really don't like is reoxygenation after a period of 60 to 120 minutes of anoxia. So the reperfusion is more detrimental to cholangiocytes than to hepatocytes. And that might actually indicate why DHOPE is protecting the biliary tree even more than preventing, for instance, primary non-function in the hepatocyte compartment. We talked about the recent trial from Robert, in which we participated, and we confirmed less ITBL, but no differences in PNF, no differences in graft survival. And I was happy that Georg showed a little of his HOPE ECD DBT trial. because I think that actually the results are pointing the same way, that also for DBD livers, an additional session of this oxygenation in the cold might help your cells and your mitochondria. So now we have to wait for Philip's trial, in which HOPE is done in any DBD liver. Can we do a functional assessment? I don't think so. If you look at the right upper panel, you can see the huge difference in energy expenditure between like 10 degrees and 37 degrees. So I think it's really hard with this low level of metabolic activity to find a test that will tell you if the organ will function if you put the temperature to 37 degrees. But as I think Georg pointed out, Dukowski showed that there is a molecule, FMN, and FMN is in the center of complex 1 in the mitochondrium. So a lot of FMN means a lot of mitochondria gone open, in which complex 1 has been freed. And this is one of the DAMPs, the danger associated molecular pattern molecules. And Philip showed that there is a relation between the amount of FMNs and a functional parameter, for instance, coagulation at day 1, and even with graft survival 3 months after transplantation. So functional assessment, this is, I don't think it's possible, but as a injury marker, FMN might become important in the future. So a small summary for the cold. Perfusion per se will prevent endothelial damage. If you add oxygen, it will prevent the accumulation of succinate. Subsequent, it will prevent production of ROS upon reperfusion, and it will enable energy increase ATP generation even at low temperatures of 10, 12 centigrade. And maybe we can do a quality check. Now for normothermic machine perfusion, I think it's a totally different concept. This is when you want to use it to assess viability, to see if the graft is actually functioning. So if you want to do this, you have to create a physiological environment, and you have to deliver oxygen to full extent. And you have to increase the temperature to actually measure this viability assessment, and you have to provide all kinds of nutrients to make this possible. And as Markus already said, you can't do that with like a acellular perfusion solution. The O2 requirements of our liver is about 90 milliliters of oxygen per minute. But the dissolving capacity of oxygen in water is only 3 mL per liter. So let's say that we have a circulating volume of 6 liters, then in our body, only 18 mL of oxygen can be dissolved, and you need 90 per minute. So that's why we need something like an oxygen carrier. He showed the study of Otto van Leeuwen with the HBOC, but actually Groningen now returned to blood-banked packet cells, because actually that worked even better than the new molecules. And it can contain over 67 times more oxygen than perfusion solution. And this is what you can see here. Be aware that if you use oxygen to load your perfusion solution, you really need to go up to this 700 millimeters of mercury of oxygen tension to get any oxygen in your perfusion solution. While if you use hemoglobin, this is about 200, even at, let's say, 60 to 7 millimeters of mercury, like in normal physiology. So these pictures, you know, and I think Markus already told us, if you see this liver in static cold storage, or the right panel liver after perfusion, as a transplant surgeon, I would definitely take the right one, and I probably won't take the left one. So being able to see how the liver is looking, if how the texture of the liver is and how it's well perfused, is very important for the eye of the surgeon. But a liver starts to work, it starts to make bile, and this is a picture from Robert Porter. Actually, the bile in the bilirubin in bile is increasing, and after some 5-6 hours, you can discern 2 types of livers that actually make bile or they won't make bile. And Chris Watson looked into greater detail, and he defined a hepatocyte panel and a biliary panel to come up with these rules for viability testing. And I think this is a very nice paper in which he saved 22 discarded livers with only 1 PNF, 1 EAD, but remaining 18% ITBL. And that's because the biliary panel is not well defined yet. This is the VITAL trial that Markus also showed from Heineck and Birmingham group. And they used a lactate level as a cutoff of 2.5 millimoles. I'm not sure that's actually a very good one, because if you go back one, Chris showed that also livers that won't make the call actually cleared lactate quite well. So lactate clearance is a poor liver function actually. But still then, using the other criteria, no PNFs, EAD was high, probably because of high transaminases, excellent graft survival, and also reported 18% of ITBL, but actually this was 3 cases in 10 cases of DCD livers, so this is up to 30% ITBL. The Peter Friend paper, I think, excellent results in terms of no PNF, 95% 1-year survival, actually a very low level of ITBL even in the cold stored DCD livers. So this is remarkable, and probably it couldn't be made better by machine perfusion, but they chose, let's say, clinically not so relevant endpoints of transaminases and EAD, which is associated to transaminases. And a lot of livers in the standard cold storage group were discarded, while this was a group that upfront was considered as transplantable. So I think this is exceptionally high, 1 in 4. Actually, for me, this indicates that if you have a standard criterion liver, normothermic machine perfusion is not helpful. It won't make it better because it's good after all. Combining things, yeah, that might be the solution. This is the latest protocol that now Groningen is using for discarded livers or extended criteria livers. They do 1 hour of HOPE, 1 hour of gradual rewarming, and then 2.5 hours of normothermic machine perfusion assessment. So repairing and testing in the same protocol. They were able to save 11 out of 16 livers. They had hepatocyte criteria, lactate, pH. They had biliary criteria, the amount of biliary production, and also the pH of the bowel. You can see this in the panels. Green are the accepted livers, and in red, the discarded livers. They had 1 case of ITBL, and then they re-looked at their biliary protocol, and they said, okay, we don't have to look at pH per se, but maybe at differences between perfusate and bile. So, for instance, a ratio or a difference between glucose in perfusion fluid and bile. And if you would have done that, actually the separation of the grafts would have been better, and probably this ITBL could have been prevented. So the summary of the normothermic machine perfusion. Normothermic machine perfusion gives you full functional hepatocyte testing. If you do it, you have hardly PNF, maybe 1 case in your series. As NMP per se is not protective for biliary injury because you only see what's happening in your recipient, you're not preventing it. And if the liver is good enough, NMP, I believe, is not making it any better. You just see that it is good. And the time to judge is at least 2.5 hours, sometimes 4 hours, but usually the protocols go up to 6 hours. If you combine injury repair with testing, probably you have best of both worlds in ischemically injured ECD livers. And the functional measurement of the cholangiocyte compartment is getting clearer now. Probably we have to look at differences in ratios rather than absolute numbers. And this is leading to the final summary. Oh, well, just 1 slide on subnormothermic machine perfusion. I think it's unknown territory. This is a nice study from the group of Heidi Ye from Boston. She did take discarded livers with more than 30% microsteatosis, perfused at 22 or 37 degrees centigrade. And interesting, at low temperatures, the livers had more energy because they didn't have to work so hard. They had less function, but also less defense. For instance, glutathione, which is one of the most important antioxidants, was much lower in the subnormothermic machine perfusion group, because also the synthesis of glutathione, it will cost energy and it needs temperature. So I think we have to go very careful in this field, and maybe this could help in steatotic livers, but I'm not sure. Maybe they just need full temperature to get all the cell repair mechanisms in place. So to make some kind of a decision making, if you have a standard DBD or EC DBD, the proof is underway, and believing what Georg is telling us, probably D-HOPE is better for these livers. If your liver is ischemically injured and this ischemia needs to be repaired before reperfusion, as is in all DCDs, I think we have now level 1 evidence that D-HOPE can do that for you. If you are worried about PNF, that actually the liver is not working, then you can test this with NMP. But these will be probably all ECD DBD livers, for instance. And if you are worried about PNF and there is ischemia damage, then you have to do a combined protocol, getting rid of your ischemia damage and then testing your liver. And be aware, if your liver is ischemically injured, but you only do NMP, you might end up with ITBL in 20 to 30% of your cases. Thank you so much for your attention, and happy to answer your questions.
Thank you, Jeroen, a fantastic talk. I'd just like to ask you a question through Yuri Botten from Brazil. The literature suggests that therapeutic intervention during NMP may modulate donor organs' metabolism despite gross production. Deflating, defatting, and anti-inflammatory administration during NMP are some examples. Please comment on this. Would it be possible to reverse or mitigate activation of the inflammatory pathway during NMP? That's a very appropriate question, but
yeah, I think these are excellent questions. I think the damage that's already present before your warm reperfusion, if you can repair this, why not do that? I totally acknowledge that if you are on normothermic machine perfusion, actually normal cell repair processes will start, and maybe we can help that by anti-inflammatory therapies. And even probably if livers are not well enough to transplant right away, prolonged normothermic machine perfusion, for instance, like 3 days, will enable you to do any therapeutic, maybe stem cell infusion, pharmacological intervention, and even defatting might be. I think Yuri himself showed that it only takes 24 to 48 hours to get rid of like 50% of fat in your liver. So I think a lot is possible on NMP, but that's therapy, not testing. So I think that's really the next level.
Amelia.
All right, thank you very much for a very interesting talk. I found it very interesting the slides you presented on the older study regarding cholangiocellular injury with anoxia versus reoxygenation. What are your thoughts about the relevance of the cholangiocytes themselves, or if it's more important to preserve the peribiliary apparatus, if you will, the glands and the arterioles, as has been seen through some of the work from Dr. Porte's group?
Yeah, I think that's pivotal, because they showed that actually more than 50% of your cholangiocytes are gone anyway, even in well-functioning grafts. But the problems start if there is arterial necrosis in your biliary glands. So probably these are the stem cell niches from which your biliary tree can be repopulated. And again, then the recent paper from the Cambridge group, in which they infused cholangiocytes retrograde in the bile ducts, and actually they repopulated the bile duct with their cells. Probably those cells ended up in these peribiliary plexus. So I think that you might sort of your biliary tree might survive a lot of damage, as long as the stem cell niches, the biliary glands, are still viable. But yeah, you have to do this by, for instance, Ki67 staining, and probably your pathologist will not do that overnight.
And I wanted to ask all of the panel really what they would see as endpoints of future trials to convince commissioners to implement machine perfusion in national programs. And that's actually a question from Andreas Schlegel. I wanted also to see, I mean, all of them, but
yeah, there's Georg.
Yeah. So
well, maybe I can start, because this is just a process that we are in now in the Netherlands, because we have like a 1 or 2 year conditional funding to see how this works out, because our Ministry of Health department is very much afraid that we will put any organ on the pump and make things exceptionally more expensive. And now they want to know what's in there for them. So actually what I think is that you need to show the global picture, that maybe it's cheaper by preventing retransplantations, procedures like ERCP, stenting, whatever. So it's not only about the 90 days or 1 year graft survival, but maybe the big picture, also incorporating costs for the hospital or for society is important. But we find it very difficult because the sets are paid by surgery, and the costs are not made by the endoscopists. So it's difficult to see who is really benefiting from this.
Markus, Georg?
Yeah, no, I think clearly we need clinical relevant endpoints, but I think we have to study the right groups. We don't need any organ perfusion for the good grafts. We have to identify the marginal population, the DCDs, the grafts you wouldn't take. So we have to say, okay, can we convert declined grafts into accepted grafts? Are we increasing the donor pool? This is, I would say, a key endpoint. And are high-risk populations doing better?
Yeah,
sorry, carry on.
No, go ahead.
No, I just wanted also to agree on that. That I think it's really time for trials with non-healthy organs. So most of the trials which were done until now, or RCTs, let's say, for example, the Nature study, those were really healthy organs. It was a feasibility trial showing that we actually do not harm those organs. It's a landmark paper, but I think now it's time to show clinical relevance endpoints. So, for example, for our trial, we chose a comprehensive complication index as a endpoint, and it's quite modern now. I mean, we have discussed this with Peter Friend and Philip Dudkowski, and we chose this endpoint at the end. But there is a general trend towards more clinical endpoints, complications, or this is quite popular at the moment. So that's the endpoint, for example, we chose.
And also, it might be different for different parts of the world, because I know in the United States, because of a lot of reasons, many DCDs are not accepted, while in other countries, these DCDs are accepted without any therapy. They're just being put in patients. And probably this is the same for DVD grafts with Georg. The ones that we not are accepting are usually shipped to Germany, because they are so desperate. They will take whatever we don't accept. So I think it's really difficult to define what is discarded.
I think we have still a little bit of time. I think Luciano's connection is gone and is trying to get back in. But going back in normothermic machine perfusion, I mean, I think Markus rightly said, they were probably understanding that advantages and disadvantages in different fields and with different organs. But what about, we brought in timing of transplantation. What about your feelings of use of normothermic machine perfusion right now for what is doing its best, so preserving good organs for longer period of time and avoiding, transplantation at night? That I can tell you myself, after 28 years or so, it starts getting a bit heavy.
So actually, So in Canada, it's different than in Germany. We have actually ORs reserved for transplant. So we do not necessarily cancel our daily list. For us, it's a big benefit if we can arrange for the transplant in a reasonable way. We can postpone it till in the morning. We get some more results. So we don't have the pressure of we have to do it at night to make sure the hernia repairs are going ahead in the day. So for us, it's a big benefit. It's logistically, the surgeons love it. The anesthetists love it. We know when it's happening. It's a big deal. In addition, what my personal experience is, it's hard to decline a graft that works well on pump. So when the numbers look not so good in the donor, people might be prone to decline, be risk averse. But once it's on pump and it makes bile and it's functioning well, the threshold to turn this organ down is much more difficult. So I think there is a benefit to perfuse the liver first, warm, if it's a bad graft, and then offer it to the surgeon afterwards and saying, okay, this liver is on pump for 4 hours, it makes bile, the pH is like this, it uses glucose. Are you still not interested? I think there is actually a reason for retrieval centers, organ assessment, delaying it, getting more information, and then asking the same question again. Do you really don't want this liver?
Amelia, Jeroen, Georg?
Well, I naturally I feel these things, but I know that for us it would be very difficult to let the surgeon night rest justify a 10,000 euro filter kit. So they say, okay, you are on call, and then you sleep next day. So I know this is true, but I think it's very difficult to get it reimbursed for this. If you can't show that it's better for your patient, it will be difficult. And the other thing is that, accepting a normally pink perfused liver is easy, but then machine perfusion is a very expensive way of another test that we should make before, so that if the test is good, you should accept the organ, right?
So can I say something really quick? Sorry. I think the logistical issues aside, do you really think that we're at a point now where we can honestly say that we have good criteria for determining graft viability, and not just hepatocellular viability, but biliary viability? Are we more just making ourselves feel good about our decisions, or maybe realizing that we could probably accept more grafts than what we already do? Or are we really truly testing the viability? Are we really determining which grafts are going to function and which are not? Because I think that the VITL trial is very, it's very interesting, but also that, along with the Chris Watson study, which also transplanted 22 grafts from the UK after viability testing, the rates of ITVL were still relatively high, and these were discarded livers. So maybe this is a reflection more of we probably reject grafts that we could transplant successfully, but are we doing anything really with the machine other than making ourselves feel better, I guess, about what we're going to do?
Well, we know the criteria are sort of we're not fully scientific. We don't have the amount of data that we would need to make really strong criteria. We made the criteria, Heineck at the time, and the group made the criteria they felt that were best at the time, but we've seen again lactate failing us, and in some occasions it has happened that livers that looked good on the normothermic machine device actually had not worked, and or gave quite a pretty strong reperfusion syndrome, and that's been shown by Chris Watson as well. But I think, of course, there is, as you say, we don't have tools yet to determine exactly whether a liver is going to work or not. Markus, do you think we are at the point where we can certainly decide whether a liver will work or not, or it's just?
So I feel good about primary function. I think the liver on pump that has characteristics is very unlikely to be a PNF. So I think this hepatocyte function, in my view, can be well predicted. biliary function is much more difficult, and this is hard to predict at the moment and not yet quite there. Both UK trials used very extreme conditions. They had quite long cold ischemia before it go on pump, and then sometimes they cooled it again for some hours before the transplant. So they pushed the envelope too far, in my view. So I think they just, I think you just have to realize that the warm perfusion is likely not reversing the injury. It shortens cold ischemia time and loss assessment. So if I do not shorten cold ischemia time, the benefit is likely lost. So I think we need to have a system where the liver goes on warm pump very quickly with a very short cold ischemia time, and then we look for biliary or hepatocyte function. If I have a 12 hours cold ischemia time already in a DCD, I probably missed the boat.
I don't think we're pushing boundaries already with DCDs with cold storage. So I think we are just ahead of time with the technology, and we found our boundaries. I wouldn't be so harsh with the UK.
I think it was a great study. I mean, it was an amazing trial. I totally feel they're doing the right thing. They're perfusing organs that are declined. This is what this technology is made for. We're not looking for the good grafts. We're looking for the bad grafts. And just we have to figure out how bad can they be? What is our limit in this regard?
But I think we are also not just looking for the very good and for the very bad, but at least in Germany, we, I don't know, in my opinion, the future of mesh perfusion is not in discarded grafts, because discarded grafts in every country are very different. So I think the discarded grafts in the UK are completely different organs than in Germany. And I think the future of German, let's say, mesh perfusion won't be discarded grafts, because they're so extremely, let's say, longest cold ischemia time, fat, and so on. So I think the future will be to make transplantation safer and better for ECD grafts, all the grafts in the middle. So, and in this regard, in my opinion at least, PNF is not the most, I mean, it's not the biggest issue. I think the overall, I mean, how many PNFs do we have? Not so many, to be honest.
No, but EAD as well is not that relevant, because I can tell you 60-70% of DCDs were EADs because of the transaminases criteria, and they did fine. And actually, we never found a correlation between AST and biliary complications.
But also, Germany has not many declined grafts because they don't do DCDs. I mean, once you start doing DCDs, you will have also declined grafts. Yes, so you have, of course, the problem of legislation and perception. You just exclude the big pool of donors that could fix the problem.
That's true, of course. Yeah.
The other issue, for example, in recent years in the UK, is that in trying to get more grafts, they really opened the gates in terms of offerings. And what was thought to be unthinkable to offer 3 years ago, now is being offered. So get thousands of phone calls at night for offers that are really not suitable. Now, there is, I hope he doesn't get upset if I call him an old-timer like me, a DCD old-timer, because David Reich from Philadelphia was doing DCDs when we started in the UK very early on. And he compliments all of you for a presentation. And in terms of DCD trials endpoints, should we look at clinically relevant strictures requiring intervention, or should we do MRCP for every study patients, being thorough and scientific? But thus looking at many clinically relevant anomalies, creating anxiety in study patients and leading to some subsequent unnecessary ERCPs. Should we do MRCP in every patient? It's definitely because of a difficulty in defining ischemic cholangiopathy. Some call it non-anastomotic strictures. Most studies looking at this have done MRCPs, but should we include that in every trial? Is that your question? I think that's a question from David Reich.
if I may give a suggestion, don't do that. We did this for the DO trial, and it gives a lot of trouble because the interpretation of MRCP is really difficult, especially when the patient is doing well and bilirubin is low and there's no itching. What does it mean?
Everyone has got ischemic angiopathy, but then they live well thereafter.
So also in our study, a lot of radiological finding without clinical substrate. So that's really difficult. So we should follow that up, and maybe after 3 years, if they all develop problems, then it turns out to be relevant. But for now, we don't know what to do with it, actually.
I think the alkaline phosphatase is a good marker. If alkaline phosphatase is low and bilirubin is low, it's very difficult to justify any further thing. But if the alk phos is like 600, even the bilirubin is low, you have a problem. And then you may want to know, and because this liver will have a problem down the road at some point in this regard.
And gamma GT. I think it's the clinical relevant ones that are the ones that we should target, and even out of those, not all of them end up in being retransplanted, and some go on many years with a slight cholestasis or so, but doing well. I don't have any further questions, and I think we are in good time. Amelia, would you like to wrap this up? And
yes. So I'll just so I'd like to thank everyone. We'd all like to thank everyone again for joining us, and invite everyone to join us for the next webinar supported by Bridge to Life on April 22nd. This webinar, we will review the guidelines that were created at the 2020 ILTS Consensus Conference in Venice, involving DC liver transplantation and machine perfusion. So please join us for that conference coming up soon. We'd also like to invite everyone, if they haven't done so already, to sign up for the Virtual Congress 2021 of the ILTS, ELITA and LACAGE. So that'll be coming up next month, actually in less than a month now, and we're really excited to have everyone join us there. And finally, just to reiterate, we're very grateful for the support of Bridge to Life for these series of webinars. This is the second series we've done. This is a great forum for us as professionals and as a society to join together and discuss a very interesting and highly pertinent topic. So thank you very much for your time today. And we hope you join us again on the 22nd and again in May. Thank you.